Thank you, Dr. Arora, for inviting me, and thank you for staying back. I know this is out of the schedule, and Dr. Arora has given me 5 minutes. I will try my best to finish within that time. We've all heard some very fantastic talks on how to manage different cases of diabetic macular edema, and I'm sure you've learned a lot from these talks, as I have. However, I'm asking you a slightly different kind of question. What are you doing for your patients before they reach these stages? Do you have a plan to screen them properly? And I hope that from my brief talk, you may be able to learn some lessons which you can use in your own practice to implement some kind of a standard screening program for your diabetic patients. Now, this program is a part of in the United Kingdom. The screening program for diabetes is a part of a national screening program, and this is not just for the diabetic eye disease, but it is for other diseases like breast carcinoma and other problems. And the idea was, the principle behind this was to see whether we can reduce the incidence of blindness related to diabetic eye disease. And as some of you may be aware, the diabetic eye disease is the most common cause of blindness in people of younger age group, working age group, in the Western population, and I'm sure the incidence is increasing in this country as well. And the program was started around 2006, so it's been running for around 10 years. And only recently we have now found some evidence that at least in the United Kingdom, the diabetic eye disease is no longer the leading cause of blindness in the younger age group. It has been overtaken by hereditary retinal diseases. So obviously we are starting to see the benefits of the screening program now. I am the clinical lead for the Derbyshire County Diabetic Eye Screening Program, and I have around 60,000 patients in my patch of woods. And basically, it's a very, very simple system, but very, very well quality monitored. What we do is, in the National Health Service in the United Kingdom, all the patients have a general practitioner assigned to that particular patient. So as soon as the patient is diagnosed with diabetes, the GP informs our screening program about that patient. And according to the National Screening Committee guidelines, we have to bring that patient in for screening within 3 months of diagnosis with diabetes. So all the new patients and the validated patients are given appointments within 3 months as soon as they are diagnosed. What happens on the screening visit? We check the vision, put dilating drops. Then we take 2 pictures. One is centered on the macula, and the other is centered on the optic disc. So basically we're taking 30 degrees. And after the screening is done, we grade those photographs. All this is done on an electronic software system called Optimize, which you can access from anywhere if you have access to the virtual private network. And based on the photographs, the patients are split into whether they actually need to be screened again in 12 months' time, or whether the patients actually need to go to the hospital for some kind of treatment. We have a team of photographers who are also screeners and graders, so it's a very efficient, small but very efficient unit. And as soon as the photos are taken, they are what we call primary graded first. So the photos are looked at by the screener. If there is no pathology, the patients are recalled for the annual screening in 12 months again. And 10% of these patients have the photographs assessed by a secondary grader just to maintain quality control. If the primary and secondary grader agree, the patient is recalled in 12 months. Now, for the patients who have got referable disease, which is significant diabetic retinopathy, maculopathy, or even proliferative disease, they are assessed by me, which is in the arbitration grade and the referral outcome grade. And based on what I see, I then make a decision whether the patient needs to be seen in the hospital. We also have a virtual clinic, which is a photography-based clinic where we take the photographs and we also take the OCT of the patient. The patient is not seen by the doctor on the day, but I assess the photographs and the OCT of that patient to decide whether the patient has any clinically significant macular edema. If the patient does have clinically significant macular edema, I bring the patient back to the hospital for whatever treatment is best. So this is a screenshot of the screening queue, and the grading queue which is there, and quite a few of these are dealt with by the screeners and graders. but there are certain final cues which I deal with on a regular basis. In terms of the grading itself, the screening grade is slightly different, especially in terms of clinically significant macular edema compared to the clinical definitions we have heard this morning. But basically, if there is no retinopathy at all, it's termed as R0. If there is background disease, it's R1. If there is other features of pre-proliferative or severe non-proliferative diabetic retinopathy, for example, ERMAs or multiple blood hemorrhages, then it's classified as R2. And then we have two categories, categories in the proliferative disease. R3A is the active disease where you have new vessels on the disc or elsewhere with no previous laser treatment or inadequate laser treatment. And the last category is the R3S, which is stable treated proliferative disease. We have a separate classification for the maculopathy, M0, there is no maculopathy, and M1, where you have slightly different criteria than the ETDRS, but that's the broad line. Because you remember, these gradings are done mostly by not doctors, by screeners. The grading for photocoagulation is there as well. So P0 means the patient has not had any laser treatment. P1 means that the laser treatment has been given either for maculopathy or for proliferative disease. Based on the outcome, the patient, as I said, may be recalled annually for another photograph, or may be referred routinely to the hospital, or may be referred urgently to the hospital. As with any digital system, there are some patients who cannot be photographed, and we have a separate line of management for that, which I won't go into details because of lack of time. So once these patients are graded and then they are referred to the hospital, this is the main category of patients who come to the hospital if they have clinically significant macular edema, or if they have severe non-proliferative disease, or if they have active proliferative disease. And these patients have to be seen and treated within very, very strict time guidelines according to the National Screening Committee. We also have a virtual ophthalmic digital retinopathy clinic. This is mainly to reduce the burden on the eye clinics, where we assess the patient digitally, as I told you, with the help of the OCT, but also pregnant patients. I know in pregnancy, as you well know, diabetic retinopathy can progress very quickly, and therefore these patients are kept in a virtual clinic where we assess them every few weeks to make sure that during the pregnancy and up till a certain time after the pregnancy, they are assessed quickly. Throughout this whole procedure, there are automatically generated letters which go to the patient, to the general practitioner, and to the screening committee as well, so that there is a chain of events which is maintained and documented properly. So in conclusion, this is a very highly complex triaged pathway, which is really to make sure that all the patients, all the diabetic patients, and you have to remember it's a small country, there is 500,000 diabetics, and they are all screened properly. The patient images can be viewed by up to 4 healthcare professionals. There is a fast-track system for urgent cases. And you can access the whole history of the patient. Even if the patient has been screened 10 years ago, you can access the photographs and compare the photographs. It's run by very qualified, well-trained staff. And it is regularly peer-reviewed and assessed by 19 national standards and 3 key performance indicators in the country. So I think if anything you can take home from this very quick overview is that whatever kind of practice you have, I think there should be an effort to develop a system where you not only treat the patients who come to you with advanced diabetic eye disease, but also have a system for your patients where you regularly screen them so that you can at least slow down the progression of the disease in future. Thank you very much.